So I need to introduce Dr. Archana Baser, madam.
Yes, ma'am.
Madam actually basically needs no introduction. She's a
Yes, ma'am,
great friend of
definitely.
mine, and she's really a wonderful person, a dedicated teacher, doing a lot of things in ultrasound, in fertility, and yes, currently she's contesting for Foxy president election. So we wish all the best to you, madam, and we want MP to shine on the national level. Thank you so much.
Thank you, Dr. Anjali. Thank you for your kind words, encouragement, and what can I say? For everything, introducing, and I think without the home support, you cannot rise. This is very, very important. Like when we do go to work as women, we need our family support. And when we go in our own society, we need our society support. And we want to go on the national level, you need your state support. You, as a state body's president of MPOG, have been really supporting. So thank you so much, Dr. Anjali, for kind words. And I think the topic which IFS has taken today is the need of the hour, because genetics has become such an important thing in everyday life. Today only I had one couple. So I told them that yes, like you are 41 years old and she has unexplained infertility, and I told that you will need some kind of a genetic testing. She said, yeah, I've heard about PGT, even during IVF, I've heard about NIPT, I've heard about the genetic testing. So I think this is becoming vogue of life, and our patients are aware about it. And I think we as a clinician need to remain updated about the newer developments in our field. And genetics is one of that, which is the basis of what you can say, maybe in the fertility treatment, or when the women are not conceiving, that may be one of the reason for recurrent pregnancy loss or recurrent failure in conception. So we have a very good speaker today, Dr. Fiona D'Souza, and it's my pleasant duty to introduce our speaker for today. Dr. Fiona D'Souza is geneticist. She is head scientific operations Anderson Diagnostics. She's associate professor at IRS Mysore, and she's an industry expert. She has been faculty at Fertilis Academy Gurgaon, and she has over 14 publications in high impact factor journals. She has authored books on PGT, genetic counseling. She's a member of ISAR, IFS, MSc, RG, and ESHRI. So it is really, we're looking forward to hear Dr. Fiona D'Souza, and I'm thankful to Dr. Priya Bhave and team IFS MP and central team of IFS, Dr. Malhotra, and for giving us this opportunity to introduce our guest. And thank you so much for involving me. Over to you, Dr. Fiona. To the stage is yours.
Introduction, ma'am, and my thanks to Dr. Priya Bhave and IFS for this platform. I have given a screen share request. Is my screen visible? And am I
Yes, ma'am, it
audible?
is visible.
Yes,
Yes,
it
ma'am.
is.
Okay. So very good evening, one and all. Today we are going to discuss on essentials of genetics in reproductive medicine. During the course of my presentation, I'm going to take you through some simple basics of reproductive genetics and the concepts of carrier screening, clinical interventions in genetic disorders, pre-implantation genetic testing, and genetics of IVF failure. So when we run genetic tests across the genome, there are three kind of entities we can evaluate. And all these entities come together to give us a complete picture of a genetic disease. First is, of course, the DNA. The DNA remains stable throughout our life. The RNA changes from time to time, and it is the expression of genes can change based on a particular time frame. And then you have proteins, which are the final result of the changes on the DNA through the RNA. If you look at the entire DNA, it is made up of chromosomes, and chromosomes are nothing but strands of DNA wound around nucleosome proteins. Certain regions of the DNA are designated genes, and each gene codes for one particular protein. Within the genes, you have exons and introns. Now, these entities are important. Exons are what we call coding regions of the genes, and introns are the regulatory units of genes. If you look at the human genome, we carry a total of 46 chromosomes, 1 to 22 autosomes, and then the last pair of sex chromosomes. They are designated based on their size and, of course, their banding signature pattern. Okay, if you look at the entire human genome, its functional region is called the exome. Within the exome, you have almost 20 to 20,000 to 25,000 genes. These are functional regions of the genome. And if there is a defect in any of these regions, we have a manifestation of a genetic disease. Now, the DNA is nothing but the blueprint for our body. And if the blueprint gets broken at any point of time, it is not easily repairable and therefore results in manifestation of diseases. And these diseases then transmit to our next generation. So there are many different types of genetic disorders. The first type are numerical chromosome disorders. These are the most frequent disorders that we encounter in our day-to-day clinical practice. The most common being aneuploidies. Aneuploidies are mainly of two types, either trisomy, where a single chromosome is in an extra copy, or a monosomy, where a single copy is lost. You also have another category of chromosome disorders called triploids and haploids. Haploids are when you have a single copy of all the chromosomes instead of two. Every chromosome needs to come in two copies, one copy from the father and one copy from the mother. In case all the chromosomes are in three copies, you get triploidy, and triploidy is not compatible with life, often results in miscarriages. If you look at the common chromosomal changes, which is trisomies and monosomies, the most commonly involved chromosomes are chromosome 13, 18, 21, X and Y. So we have Down syndrome, Edwards syndrome, Patau syndrome. All of us are familiar with this because these are the three chromosomes we routinely screen every pregnancy for. And then you also have the risk of sex chromosome aneuploidies like Turner syndrome and Klinefelter syndrome. Now, within the aneuploidy segments, we have two main types. We have a whole chromosome aneuploidy, which means that the entire chromosome is missing or in extra copy. And then we have segmental aneuploidies, where parts of the chromosome are missing. Segmental aneuploidies vary in size. The size determines how many genes are lost and what is the impact of that change. Another type of genetic disorder are called structural changes. These are changes in the design and structure of chromosomes. The most commonly known condition is translocations. Here, two parts of two different chromosomes can break and interchange their location. So it's basically transfer of location. And if an individual is carrying a translocation and healthy, usually they will be balanced translocation carriers. We can also have small parts of the DNA that can go missing, deletions, small parts of the DNA that can replicate and have come in two copies called duplications. And then you also have inversions. Inversions happen when a part of the chromosome breaks, inverts upon itself and reinserts into the chromosome. Now, as and when these chromosomes are inherited, when gametes are found based on these chromosomes, they can disturb the resulting chromosome complement of those gametes and result in either miscarriages or fetal anomalies. In the balanced translocation category, you need to remember two main categories, reciprocal translocations and Robertsonian translocations. If they are balanced, the individual is healthy, they have reproductive risk alone. If it's unbalanced, it results in a miscarriage. So here is an example of a couple, primary infertility, weren't able to conceive, went through ART. And in the first transfer itself, they were able to conceive. And NT scan at 11 weeks was indicative of generalized edema, single umbilical artery, and omphalocele. Now, usually when there is a first pregnancy loss, we do not intend to test that pregnancy, but that's not the case with ART pregnancies. Because achieving a pregnancy through IVF is challenging, if there is a fetal anomaly or there's a miscarriage in an IVF pregnancy, we would prefer to test them first to get an idea if the problem is chromosomal or not. And based on those results, the next cycle is planned. So fortunately, in this case, we did go for the testing of the fetal sample with the chromosomal microarray, which is a go-to test for prenatal for product of conception testing or fetal anomalies. And we were able to find a duplication, that is gain of 36 MB on chromosome 3 and a loss of 3.5 MB on chromosome 7. So this is a typical presentation of an unbalanced product. So once this result was ready, we decided to look into the fact that is it inherited from the parents or not. And when we went back and did the parental karyotyping, we found a translocation between 3 and 7 in the male partner. What we need to remember here is when we went back to the parents, we did not do the microarray. We did the karyotyping.
Okay.
Okay. So here you can see there is a small
गरम करना पड़ेगा हाँ गरम करना पड़ेगा चलो तो हल्दी डाल तो आ जाएगा
somebody
I request all the participants to mute themselves. I will.
So in this case, you can see part of chromosome 3 has moved to chromosome 7 and vice versa, and therefore you have a balanced translocation in this individual. This individual is asymptomatic, very healthy, only challenges during the reproductive cycle. Now, the next category of genetic disorders are called mutations. These are single code related changes on the DNA. Usually, when you come to mutations, we have mainly focused on single gene defects. These are single genes responsible for a single trait. Therefore, when that particular gene is defective, the protein gets affected and the disease is manifesting. The most common condition we come across is sickle cell anemia. The mutation for this disease is located on the hemoglobin gene called HPB. And if this gene is defective, it affects the structure of the hemoglobin protein, therefore causing sickling of RBCs. Now, within mutations themselves, you can have a single code on the DNA which is changing, which is called a point mutation. You can have a single base pair or more than one base pair missing, their deletions. More than one base pair which is inserted, we call them insertions or duplications. Here too, you have inversions as well. These all manifest under the single gene category as well. When we find mutations and we run genetic tests, they're mainly divided into 5 categories. And the main 2 categories which are reported are pathogenic and likely pathogenic diseases. Pathogenic diseases are definitive mutations which have been reported to cause a disease. In the likely pathogenic category, it means that in about 90 to 95% of cases carrying this particular mutation, the disease has been manifested. So it's mainly a literature and a database driven categorization of variants. You have the likely benign variants, which are harmless variants. We do not intervene for these variants, and most genetic reports don't have it in their reports. The middle category is VOUS, variants of uncertain significance. These are basically new mutations which do not have any solid scientific proof to state that they're disease causing, which means that as and when databases improve, more researchers are conducted. This mutation in the future can either move into the benign likely benign category or the pathogenic likely pathogenic category. Now, why is it important for reproductive specialists? When a patient comes to you with an already tested mutation report, most of you might have come across mutations which fall under the VUS category. These mutations are not directly actionable. There is a lot of background evaluation that needs to be done for us to recategorize and reanalyze this variant. If these variants are still in the uncertain category, we are not allowed to intervene clinically. We do not plan any preventive measures for these variants. If these variants appear to go towards the likely pathogenic category, we will plan preventive measures. Now, each gene is inherited in one particular manner, and it is a gene-specific trait that is usually established by research beforehand. One of the main types of inheritance patterns is autosomal recessive inheritance. Here, in each individual will carry 2 copies of the gene. One copy is normal, and if the other copy is mutated, for recessive diseases, the patient becomes a carrier. If the patient is carrying both copies to be affected, then the patient manifests the disease. If both parents are carriers of a single mutation, then there is a 25% probability of a child being affected. 25% probability of a child being unaffected, and a 50% probability of having carrier babies. We call this risk stratification, which helps in patient counseling to help the patient understand what is the probability of having an affected child. What if a patient is affected with autosomal recessive disease and the partner is unaffected? Here, based on the permutation combination, all the babies will be carriers. That means 100% carriers of that disease. Carriers do not manifest autosomal recessive conditions. Hence, we do not intervene in such cases. Unless there's a risk of a child being affected, we do not intervene for genetic conditions. Second is the autosomal dominant inheritance. Here, these are strong mutations. Even one gene location carries this mutation, it will manifest as the disease. And if the partner is unaffected, there's a 50% probability of having babies with affected condition. And another factor you need to remember with dominant condition is they can be congenital, they might present at birth, they might be late onset diseases as well. And autosomal dominant conditions also have another category of manifestations called penetrance and expressivity. Complete penetrance means everybody who carries the mutation gets the disease. This is a clear category. But you also have dominant mutations which fall under reduced penetrance. All the people who carry the mutation may not always present with the disease. You also have complete penetrance, variable expressivity, which means that all the individuals with the mutation will manifest the disease, but they will manifest the disease in different ways, in different severities. And this cannot be predicted when the disease passes from one generation to the other. You can also have reduced penetrance and variable expressivity, which is a far more complicated version of dominant diseases. Dominant diseases can also be hidden in the germline, and blood tests basically cannot evaluate the germline condition. So some few genes are listed to have germline mosaicism, which means that a blood test will say that no, the parents are not a carrier, but children can still be affected. So this is what we call the baseline risk for such diseases. We cannot truly say that there is no risk at all for a genetic disease to pass on. The fourth category is, of course, the most complicated category for most clinicians as well as geneticists, is X-linked inheritance. X-linked inheritance mainly refers to those diseases which are passed down through the X chromosome. And since women have two X chromosomes, women become healthy asymptomatic carriers. However, male babies can be affected because males have only one X chromosome. And if the males inherit the affected X chromosome, it will manifest. So here's how the inheritance goes. It's a common misconception that women who are having X-linked recessive diseases as carrier status cannot have healthy male babies. They think, oh, all the males are going to be affected. This is not the case. Women who are carriers will always have 50% of the male babies healthy, 50% of the male babies affected, 50% of the female babies fully healthy, 50% of the female babies are carriers. So all in all, whether irrespective of gender, the risk is at 25%. If you look at gender-wise risk stratification, 50% of males will be affected. We can offer them interventions to ensure that we are eliminating the possibility of an affected child, but these interventions cannot really tell you if it's a female carrier babies because of PCOS regulations. Now, what if you have a male who is affected with the X-linked condition? The most common type of condition is hemophilia. So if a male is affected with hemophilia, now hemophilia can be mild, hemophilia can be severe also. So certain milder forms of hemophilia can exist, and these males, when the female part is healthy, will have all their female babies to be carriers, and the male babies will be completely healthy. We often get such cases saying that we would like to do PGT testing in the embryos, or we would like to do prenatal testing. However, here in these cases, since there is no risk for children to be affected, we cannot offer them preventive techniques, mainly because we are restricted by PCOS in our country against selection of gender before delivery. Now, there is a clause in the PCOS which tells us for diseases which are X-linked, you can diagnose. So true, if there is a risk of a child being affected, I can diagnose and say, yes, child is affected, or no, child is not affected. But you can't really diagnose the carrier status without indication. So genetic disorders, as I said, can be not just mutations, deletions, and duplications. You also have another category of disorders called repeat expansion disorders. The most common one is Fragile X, Huntington's disease, spinocerebellar ataxias. These fall under repeat expansion disorders. You also have epigenetic disorders and polygenic disorders. These disorders are handled by multiple genes, so there is more than one gene responsible for the disease. Mapping these disorders becomes slightly more challenging for preventive measures. Of all the disorders, we usually have two main inheritance modules. First one is inherited, that means it's passed on from parents. The second one is de novo, which means it's happened for the very first time. In inherited diseases, based on the type of inheritance, we tell you risk 25%, 50%. If it is de novo, you fall under the low risk category. This is 2%, which is the general population. We should remember that when it comes to genetic testing, there is no one test which can cover all of these 6 types of diseases. Therefore, we have multiple modalities like karyotyping, Sanger, MLPA, next generation sequencing, microarrays, TP-PCRs to choose based on the genetic disease. Therefore, you can't just say one test and say it covers all. Just to take you through a few of these techniques. Karyotyping is a traditional technique. It's a gold standard technique to look at the structure of chromosomes. It is the main test which can diagnose balanced translocation carriers. No other test like the microarray NGS can diagnose balanced translocation carriers. Therefore, if you have a patient with recurrent pregnancy loss, you can never skip karyotyping of the couple. That's the first test that we start with. FISH basically is fluorescent in situ hybridization. This is a targeted technique. We frequently use it in prenatal testing. FISH is a target-specific probe. So if I know exactly what I'm looking for, we can design a FISH probe for it. Microarrays are a molecular platform. When we say molecular platform, it means that we extract DNA out of the sample and run it and sequence it in particular ways to understand different features of the genome. So microarray basically is a higher resolution tool. That means it can visualize chromosomes better than the karyotyping. The main purpose of the microarray is to detect deletions and duplications across the genome on any chromosome that you want to. The advantage is the resolution. It is 10 times higher than the karyotyping. Next generation sequencing is a newer modality to sequence the DNA. For these cases, we can look at multiple applications, whether it is looking at a single mutation, many genes, we can do RNA expression, we can do methylation studies, we can do multiple applications on the next generation sequencer. When do we use this test? If we are suspecting recurrent pregnancy loss or disorders of sexual development, karyotyping is my first go-to test. If we know exact clinical diagnosis of the disease, for example, it is thalassemia or polycystic kidney disease, I know exactly which gene I need to look for these diseases, then we go for a targeted testing. Targeted testing can look at a single gene or a single mutation also, based on if we can choose the platform. Clinical exome is a smaller panel, about of 6,000 genes, the most common clinically significant genes in a particular population, mainly used for consanguineous couples, neonatal deaths, deafness, mutism, dwarfism. These are common genes involved, so they are loaded into that panel. Whole exome sequencing looks at the entire active regions of the genome. Companies will provide you whole exome panels anywhere between 22,000 genes to 25,000 genes coverage. Now, in India, the difference between the clinical exome and the whole exome is marginal, hardly 2,000 rupees. And since patients pay out of pocket for their testing, it is preferred to go with the whole exome testing so that we have maximum coverage in one go as opposed to the clinical exome. And obviously, because the coverage is more than 2 times of the clinical exome, the whole exome is more informative. We also have mitochondrial genome sequencing, which is mainly a panel of 48 genes focused on mitochondria-related diseases. And the key indication is when all the babies of a particular woman, irrespective of them being male or female, are affected with a similar presentation. Because we inherit all mitochondria from our mother. Mitochondrial genome sequencing is not the go-to test for defective oocyte quality. Okay, it's mainly for genetic diseases associated with mitochondrial dysfunction, and that does not refer to oocytes. It's basically mutations causing neurodevelopmental delays also fall under mitochondrial genome sequencing. So NGS panels have mainly three categories. Targeted panel, I can make a few genes, I can make a single gene, and we have panels for multiple diseases. For example, we have a female infertility panel. The panel will focus only on genes associated with female fertility. It won't look at anything else. The exome sequencing panels looks at only active regions of the genome, that is the exons, which covers 20 to 25,000 genes. Then is the whole genome sequencing. The whole genome sequencing looks at both the coding and non-coding regions, exons and introns. It takes longer turnaround time and it is far more expensive. It is at least 5 times more expensive than your whole exome sequencing. So usually in clinical practice at the moment, we use exome sequencing alone, whole exome sequencing. Genome sequencing is now upcoming mainly in the field of neurology and oncology. So why is the diagnosis of all these diseases important? Genetic disorders are rare. It is the pure definition of a mutation is that its frequency is less than 1% in the population. But if you look at genetic disorders, even in a small population like a European population, you have 1 out of 12 people being affected. When it comes to the Indian scenario, you have a huge population, but you have mainly an endogamous population. That means we marry within our particular religious groups, and mostly consanguous marriages also mainly in southern India. This has resulted in multiple mutations being acquired and have compounded over generations. The challenge genetic disorders are that more than 80% of rare disorders are genetic. Of the genetic disorders, 7,000 of them are chronic diseases, and only less than 5% of them have treatable drugs available. So when it comes to genetic disorders, prevention is better than cure. So what are the most common disorders we see in our country? Of course, thalassemia and sickle cell anemia. We are well aware of it. But what most people don't realize is the carrier status of SMA, spinal muscular atrophy, is also very high in the Indian population. It is 1 in 38, touching to a carrier frequency similar to that of thalassemia. So when we screen patients for thalassemia with HP electrophoresis, you need to make sure that SMA screening is also included. However, unlike HP electrophoresis, which is so carrier screening is a test that is used to identify individuals or couples that are at risk of having a child with an autosomal recessive or X-linked disorder. Now, in most individuals, there's a child affected, so we know we have to go for carrier screening. But some individuals prefer to perform these tests before a child can actually get affected, and this is ideal because any one of us can appear healthy but still carry a genetic mutation. So preconceptional carrier screening is basically offered to any individual who is planning a pregnancy. This can be done either if they have a previous child affected with a genetic disorder, or there's a family history of a genetic disorder, or if they have consanguinity, they are consanguinously married, or there is a history of consanguinity in the family, or it can be also offered to individuals planning ART cycles or to donor gametes. It is important that a pre-test and a post-test counseling, genetic counseling offered while performing carrier screening tests. This is mainly because carrier screening tests have different coverages. So patients should not be under the impression that we have covered every genetic disease under the sun. So the most frequent diseases are basically alpha thalassemia, beta thalassemia, cystic fibrosis, DMD, SMA. And these are the basic tests that have to be included in a base level panel. That is the recommendation. Most of the companies will have around a 3-tier testing kind of panels. First will be the baseline panel, can have around 200 to 450 genes, and then SMA plus DMD is extra. This is because these 450 genes are basically screened for mutations on next generation sequencing. SMA and DMD are tested on a different platform called MLPA. Therefore, it says plus SMA plus DMD. If you are choosing a genetic service provider for carrier screening, always check how many genes are covered in your panel, plus have you covered for SMA and DMD. Now, expanded carrier screening is an extended version of this screening panel. You can cover 2,000 genes, again, SMA and DMD extra. If you want to go for a more comprehensive approach, you can add whole exome sequencing plus SMA plus DMD. Now, we frequently get requests from clinicians asking to do whole exome sequencing in couples for carrier screening purposes. but many clinicians forget about SMA and DMD. So these are two important tests that have to be incorporated. SMA has to be done for both the couple. DMD needs to be done for the female partner alone. Karyotyping is not included as part of carrier screening panels. If you want to visualize the structure of the chromosomes, karyotyping is always an add-on, and you have to request an order for it separately. So this was a case of couple carrier screening. The female partner was 38, male partner 44, and they came with us to us with a clinical history. 4th-degree consanguineous. They had a female child who presented with the developmental delay, skin complaints, etc. And they had done the test for the affected child earlier with clinical exome sequencing, and they found a mutation on XPC gene. The child succumbed at 6 years of age. The couple's firstborn male child is 9 years old and healthy. So since this is an autosomal recessive condition, you can see here mode of inheritance is AR, reproductive risk 1 in 4, and here is the classification of the mutation, likely pathogenic. This information gives you the gene, the location of the mutation, the protein change, and the zygosity in the parents. The most important is this number over here called OMIM. This number basically helps you understand the manifestation of this disease. So if you just copy paste this number on a website called omim.com, it will take you exactly to this disease and its clinical presentations, its inheritance, and its population frequency. If you don't have the time space for this, genetic counselors can help you with this. Now, when this couple they did their index child already. So when they choose the testing for themselves, we give them two options. Either you choose to test only for XPC, or based on your history of consanguinity, you can choose an extended panel like whole exome sequencing, which has better coverage, eliminates risk of other diseases because they've already seen a child suffer and pass away. When we did the testing, we found that the male partner had 3 other variants to be carriers. We saw all red lines and were worried. But the female partner was not a carrier for those mutations. And all these 3 mutations are autosomal recessive in nature. And therefore, there is no risk of a child being affected. So we plan to intervene only for the XPCD. So here is an example of a donor carrier screening that came to us. Now, the couple was extremely anxious, refused to provide us any clinical history. And therefore, this is a direct testing for the whole exome sequencing without any clinical history. Now, when we do a testing without clinical history, you might miss out a lot of information. If I do a test like whole exome sequencing, the analysis team finds around 1 lakh mutations, and we do not report them unless they are clinically significant. Now, because these 5 variants are part of the Indian database, the team choose to report it. Now, this donor had 5 mutation carrier status for autosomal recessive. The donor was not affected, but this is only 1/2 of the DNA. Now, unless I test the intending male partner, I don't have a correct reproductive risk assessment. So while performing donor carrier screening, it is important that it is done together for the donor as well as the intending biological parent. And then we can clearly interpret and say, yes, you can choose this donor, and no, you cannot choose this donor. Based on the donor report alone, you cannot decide to choose or reject a donor, because all of us can be a carrier of 1 to 5 genetic variants in autosomal recessive status. So key points to consider in donor carrier screening: dual screening is imperative. Either the intending couple or the intending biological parent and the donor needs to be tested. You can choose this panel coverage. Make sure that SMA and DMD are included during screening of oocyte donors, and SMA to be screened for both male and female partners. Another small case I wanted to put in here, because most of individuals with history of breast cancer in the family turn to their IVF specialist or obstetrics specialist. Now, this was a case of a 38-year-old woman whose mother expired due to CA breast. Grandmother had CA ovary. She has 2 daughters and a son, and she wanted to get tested for BRCA1 and 2 mutation. So when she came to us for genetic counseling, she'd already done a BRCA1 and 2 mutation, which was negative. She was still very anxious, and the clinician thought there could be more to it. There is a clinical history, yet we have not found anything. So she diverted the patient to us. Now, What we need to understand is breast cancer can be caused by more than just BRCA1 and 2. So it has a 3-tier testing. First, you do BRCA1 and 2 mutation testing. If it's negative, you need to do BRCA1 and 2 MLPA, which is a deletion duplication testing, not covered by the NGS panel. Then you need to do an extended hereditary cancer screening panel. So for this patient, based on the history, we chose a hereditary breast and ovarian cancer panel, but there is a pan-cancer hereditary panel as well. You can choose that. The cost is pretty much the same. Here we found that she had an autosomal dominant BARD1 mutation, which is in the likely pathogenic category. So definitely she's an individual who is at risk. She's 38 years and she needs to be kept on surveillance. Had we stopped at BRCA1 and 2 mutation alone, her lifetime breast and ovarian cancer risk would never be known to her, and even she would fall prey to the disease. So it is important to remember that BRCA1 and 2 mutations are also found in males, and their lifetime risk for in males is lower, but then in males you have higher risk of prostate and pancreatic cancer. So even though she has 2 daughters and a son, once they're 18, we would suggest all 3 of them to get tested and not just the female children. So just to summarize carrier screening, it's a couple test. It can be offered to individuals or to donors. If you do it sequentially, you would have a longer waiting period. That's the main thing. You can do it for couples who are planning pregnancy, ART, having difficulty in conceiving, can also be offered to patients with history of idiopathic reproductive failures or patients who have any kind of previous anomaly in earlier pregnancies. So how do we intervene for these genetic disorders once they are identified with carrier screening? Carrier screening identifies patients at risk, and preventive diagnostic tools help us prevent the transmission of these diseases. Usually the diagnosis is achieved either by index case testing or carrier testing. Also newborn screening, neonatal screening also gives us informative results. This is followed by parental testing. Prevention is either by natural conception with prenatal testing with series and amniocentesis, or it could be pre-implantation genetic testing. How we integrate this into the ART framework? First, based on the clinical history, preconception carrier screening is offered. The clinical history is very important. Never offer carrier screening test without a detailed family history. If the history is not available, the genetics lab is going to ask their counselors to connect with the patient and get this history. And this makes a lot of difference. So we had a case where there was no history given to us and we reported 3 variants which were not significant. Once the history came through, other variants which were associated with the disease were reported. So it is important to receive the indication segment inside the whole exome sequencing. Read through it and make sure that that information is included in the testing. So sometimes your exome report test might be done correctly, but it may not be reported all the variants we detected based on the history you provide. Then we can choose the appropriate PGT for the patient, and once post-transfer, we can monitor it out. So one of the main challenges of success in assisted reproduction is implantation failure. Why is it so challenging? The challenge is with embryos. With embryos, appearances are deceptive. You can have a beautiful looking embryo which is aneuploid, and not so great looking embryo which can be euploid, and that poor quality embryo can also give you a live birth rate. This is because chromosomal status of embryos has got nothing to do with its appearance. These are completely disassociated facts. Now, if you look at the causes behind ART failure, chromosomal aneuploidy is the most common cause. It can cause implantation failure or miscarriage, or if sustained pregnancy sustained lead to fetal anomalies. 50% of IVF-derived embryos are known to carry chromosomal mutation, chromosomal variants, that means aneuploidies, based on the age of the mother. Of course, pre-implantation genetic testing is our test of choice, and right now, pre-implantation genetic testing is performed in blastocyst stage alone. We have discontinued testing earlier embryos. Here we take a small biopsy of the trophectoderm, which is a laser-assisted biopsy, because the laser is a non-contact laser and helps us size just the right amount of cells in with minimal damage to the blastocyst. These cells that we aspirate from the embryo will usually be in the number of 6 to 8 cells. It goes to the genetics lab. Here we extract the DNA. And this DNA is very little because we are dealing with very few cells. This DNA is then undergoes whole genome amplification. That means we copy the DNA multiple times. Then we get a considerable amount of DNA in the concentration of maybe 10 to 20 nanogram per microliter, which is then subjected to genetic analysis. Now, the indications of PGTA are mainly recurrent implantation failure, where you have good quality embryos which have failed implantation. Severe male factor has also been implicated, but advanced maternal age remains the most strong indication for PGTA. Any woman above the age of 35 can be offered PGTA in view of increased risk of aneuploidy. PGTA categorizes the embryos into euploid, aneuploid, and mosaic. Now, mosaic means it's a mixture of both normal and abnormal cells, and mosaicism is charted with a percentage value anywhere between 30 to 80 based on the chromosome. So every genetic lab will give you chromosome-specific mosaicism values when we perform PGT. Now, mosaics have a cutoff of 50%. Any mosaicism below 50%, which is 20 to 50, 30 to 50, falls under the no mosaic category, and any mosaicism above 50, 51 to 80 falls under the high mosaic category. What is important to know is low mosaics tend to have better correction mechanisms and have been reported to result in healthy live births, whereas high mosaic embryos tend to go towards miscarriage or implantation failure and therefore not recommended for transfer. If you look at the performance of PGT, it's been around for many years now and tried and tested. There is humongous amount of data to support its efficacy. So this is basically the most recent SART data, which evaluated around 22,000 embryos in women below the age of 35. And when they incorporated PGT-A, we can see that the live birth is significantly better and improves with age also. But obviously, the possibility of an aneuploidy always increases with age, and this is well established. You can see that with PGT-A, the possibility of implantation is sustained, whereas without PGT-A, the implantation failure risk increases, and the miscarriage risk reduces when there is PGT-A incorporated into the IVF. This is a very interesting paper by BOT et al. And this is one of the key papers that helps us understand the ability of mosaic embryos to implant and sustain pregnancies. What is very important is, can you see here that the euploid embryo implantation rate is at 57%, and this is a European facility. So 57% euploid embryos implant, and 52% of them went on to have ongoing pregnancy or live birth reported. So here we can clearly see that about 43% of embryos did not implant despite being euploid, even in the best labs in Europe. And this is the most important misconception about PGT-A that we need to remember. PGT-A euploidy does not guarantee your pregnancy. It just reduces the risk of a miscarriage. It increases the probability of implantation, but does not say that it will definitely implant. And then comes the mosaic embryos. You can see here there is low segmental, high segmental. So segmental aneuploidies are the preferred transferable embryos. Their implantation potential is just 7 to 8% lesser than euploids. And then when you have one chromosome, no mosaic, it's 48%, two chromosomes, it is 45. So as you see, if you have high mosaic categories and the number of chromosomes involved increases, the possibility of implantation progressively lowers. The same trend is observed in the ongoing pregnancy and live birth. So the main question after we do a PGT cycle is, why do euploid embryos fail to implant? Euploid embryos fail to implant because of reasons beyond ploidy status. It is associated with both endometrial and uterine factors. From the endometrial side, it could be certain transcriptomic factors which have not been expressed, could be methylation-related factors, epigenetic factors which are regulating implantation. With the endometrium, could be asynchrony between the window of implantation and the endometrium. For example, if you have a day 7 blastocyst, do we transfer it into a day 7 endometrium or a day 5 endometrium? This is the confusion always. So when you have a fully expanded blastocyst, even though the blastocyst is slow growing, it should always be implanted into day 5 endometrium because The window of implantation in the endometrium is fixed for a certain timeline only, and it can shift between individuals. That is why receptivity is important. You could also have uterine abnormalities, microbiome imbalance, could be multiple other factors. So how do we counsel patients whose uterine embryos have miscarried? First, we need to rule out obesity, endocrine factors, immunological factors, uterine anomalies, infections, and luteal phase deficiencies. These are endometrial factors. Embryonic factors could be certain undetected mosaicism, could be epigenetic cause for which we do not have genetic tests available. So no matter how much we test embryos, we'll also always have some part of the embryo that we have not been able to test. So coming to embryonic factors, what we need to remember is apoptosis is a key phenomena of blastocyst. This is how the blastocyst repairs itself. This is how it gets rid of aneuploid cells. If the apoptosis is pretty high in the trophectoderm region, and this region is interacting with the endometrium, you will not be able to establish implantation. There is no test right now which enables us to look at the apoptotic index of the blastocyst. And this is a key limitation of chromosomal screening. We can only screen PGT-A to tell us it is aneuploid or it is euploid, but it does not measure apoptosis. PGT-A does not measure epigenetics, and the expression of genes involved in implantation is epigenetically controlled. There could be other endometrial factors like chronic infections. So chronic endometritis is one of the main factors we need to rule out while we face implantation failure, hormonal disruptions, and also you have the microbiome. Receptivity is one of the pathologies. This is a quite debated test. I don't want to get into its details, but it is not under the standard recommendation for RIF at the moment because the evidence is not strong in favor of evaluating endometrial receptivity. The reason this is so is because every genetics lab has a different panel of genes to a certain receptivity. The second most important fact is every woman who gets pregnant or does not get pregnant can have variable sizes of the window of implantation. So usually most women have the window of implantation lasting for over a period of 48 hours. This period can be as long as 3-4 days also, and it could be as short as few 6 hours also. And this is the main limitation in establishing a gold standard in evaluating endometrial receptivity. You also have endometrial dysbiosis. This basically evaluates the presence of lactobacilli in the endometrium. But why lactobacillus dominance is important in the endometrium is that it maintains a pH which is on the lower side. The low pH hinders the growth of opportunistic bacterial, which could be infectious in nature, and also facilitates in implantation. Immunological factors are an upcoming investigation that looks at the HLA typing of the couple, that looks at the key typing of the female partner. You can also look at the immune regulation of the endometrium. The basis of this part of testing is that the immune system is an important factor in facilitating embryonic attachment and invasion into the endometrial cavity. If the endometrial immune system, which is supposed to protect the fetus, is not activated by the right mechanism, we might face autoimmune rejection of the embryo, which is responsible for implantation failure. It can also cause challenges in development of spiral arteries in the endometrium, which again will predispose the patient to early pregnancy loss and poor invasion of the trophectoderm. Now, another factor I would like to highlight is PGT itself. The current PGT has certain limitations. The right PGT that we use right now is copy number variation based PGT. We call it CNV testing. Basically looks at only all the chromosomes and evaluates if parts of the chromosome are missing or in additional copies. But the most recent version of PGT now incorporates the copy number variation testing with what we call SNP testing. These are single nucleotide polymorphisms which are present, and what they help us do is evaluate much more information from a PGT sample than just the chromosomal status. Basically, SNPs are our individual DNA signatures which give us our own unique identity. It is also something that we use in DNA fingerprinting technology. It's not new, it's been around. This is the technology we use for PGTM as well. The advantage of putting it into routine PGT-A testing is that now I can go into higher depths of the genome, so I can give you better resolution. Earlier we were stuck at 10 MB, now we can look at 5 MB resolution. It reduces the mosaic calling, which is designated by DNA sequencing noise. Regular in this, when you have very low DNA concentrations, generates noisy signals. And when you have SNPs, it kind of fine-tunes the data that we get out of the PGT-A. How does it function? Parents have each their individual signatures from their parents, and they pass those signatures to their children. And these unique signatures can be mapped with the SNPs of the parents and the children, or the SNPs of the parents and the embryo. The biggest advantage of this modality is that it helps us detect haploids and triploids, which your current PGT-A does not report. Many clinicians are unaware of the fact that routine PGT-A cannot tell you the difference between a haploid, diploid, and a triploid embryo. It detects trisomy and monosomy, single chromosome changes. But if all chromosomes change in a similar fashion, it cannot visualize that change. It's a key limitation of the current PGT-A. So the advanced version of PGT-A now tells me the exact SNP signatures. Basically, it tells me now, is the embryo haploid, it is normally fertilized or not. Now, I find that most of the time in IVF, we don't anticipate triploidy because we do ICSI for most of our cases. However, there could be retention of the second polar body, or maybe we think the second polar body was degenerated, so the PN check is not being done correctly. Or there could be a possibility that the sperm was disomic. There could be 2 sets of DNA in the sperm itself. Even though you do ICSI, you still have a risk of triploidy. And this is why the current PGT-A is also limited, and triploidy does result in early miscarriages. So now, based on this technology, we can assign the correct triploidy based on the DNA status of 2 affected cells. So even if your embryologist misses the PN check, the PGT-A will incorporate with incorporated SNP testing can tell you the ploidy status at the blastocyst stage itself. It is suited for even abnormally fertilized oocytes. So there was a recent study that evaluated this. It showed that 63% of 1 PN embryos were actually diploid. They normal in nature. It was a false designation of 1 PN. In the 2 PN category, 1% still turn out to be diploid and haploid. And in the 3 PN category, 50% of blastocysts turn out to be diploid. So it is important to include these embryos into testing, but you need to be very careful which version of PGT-A you are choosing. Another advantage of this SNP-based testing is it gives you origin of aneuploidy. So once you have the aneuploidy report, you don't know if it is maternal or paternal in origin. And this particular testing now tells you, is the aneuploidy maternal? Is it paternal? Is it coming from the embryo in itself? It will assure you that the embryo is a biological product of the parents, and it also assesses for any exogenous DNA contamination that can be incurred during the sampling process. So this is a much more confident version of PGT-A, which is now available. Now, coming to PGT-SR, PGT-SR is offered for balanced translocation carriers, could be reciprocal, Robertsonian, or carriers of inversions. PGT-SR is a standard PGT, just like PGT-A has been around for many years, and mainly is used for patients with recurrent pregnancy loss who have a translocation diagnosed. Here, the risk of an unbalanced product is very high. Usually, it is anywhere between 50% because of the chromosomal risk, can extend until 80% because maternal age risk can compound the risk factors. So this is a classic example of a Robertsonian translocation. Here you don't have 14th chromosome. The 14th chromosome has moved to the 13th chromosome. What is important, remember, in PGT-SR is that it has a resolution limit. So if your translocation is very small, it might be beyond the coverage of the test. You still have to work with prenatal testing. And the test cannot differentiate between euploid and balanced translocation carriers like karyotype. So when we say the embryo is normal, it basically means that the normal embryo could be euploid. It could also be a carrier of the reciprocal translocation. We don't know. So this is euploid or carrier. Many times there's a confusion leading the patient and clinician to think that this embryo carries the balanced translocation. I don't want to transfer. there is a 50-50 possibility of that happening. The test cannot diagnose balanced translocation. It can diagnose unbalanced translocation, which is the second embryo. It is having segmental loss of 5 and 9, which is same as that of the male partner. It is triggered the unbalancing from in the embryo. So most important facts to remember with PGTSR, incidence of aneuploidy is higher because you have to factor in both maternal age risk as well as the translocation risk. Current PGTSR cannot differentiate between balanced and euploid embryos. They are a transferable category. However, only once a baby, if you do a prenatal testing or once a baby is born, you have to do karyotyping to diagnose a translocation, balanced translocation. Embryos with balanced translocation are healthy. And you can offer invasive testing even if you transfer a balanced embryo. And the testing you should be offering is a combination of both karyotyping and the chromosomal microarray. Coming to PGT-M, these are mainly designed for monogenic diseases. Now, there is always a bottleneck of pre-PGT workup for PGT-M. So every PGT-M company will do their own pre-PGT workup. So if you do a pre-PGT workup in company A, and then go for PGT-M with company B, they will have to repeat it. Okay. So first, the PGT-M cycle starts with the genetic diagnosis and the clinical diagnosis. So we can have a clinical diagnosis which says that the ophthalmologist has said the patient has night blindness, right? That's a clinical diagnosis. That's not a genetic diagnosis. So first we see if a genetic diagnosis is established or not. If there is no genetic testing report available, or your patient has lost their genetic testing report, they will have to redo the genetic test. The correct molecular diagnostic test is advised, and once the report is ready, it is reviewed by the genetic team, and then we ask for the parental samples plus reference samples for pre-PGT workup. Now, the molecular diagnostic test could be HBB full gene sequencing or could be whole exome sequencing. That is a mutation identifier test. That is not pre-PGT workup. The diagnostic test is only to identify where the mutation is sitting. Next, the pre-PGT workup is designed to design the probes for that particular mutation. So we will have patients that come to us, for example, they come to my company and they have done the testing, base level testing in another company. I cannot generate the probes based on that report alone. There could be errors in the designation of the mutation. If I don't see the data sequence and I design a probe without doing my thorough check, my PGT-M testing can get skewed significantly. Therefore, whether your genetic test is done in, doesn't matter which company is done. The pre-PGT workup performing company always first confirms the mutation in the parental samples, and second develops the probes around that mutation to look at the mutation and the region's SMP markers surrounding that particular region. So this is pre-PGT workup. Now, pre-PGT workup usually requires 2 generational samples. One, the intending couple, and second, either the child. If the affected child is not available, their grandparents' samples, their parent samples are asked. Once the probes are ready, this takes around 3 weeks. Then you can start your IVF cycle and plan the embryo biopsy, in which case the testing will go smoothly without a challenge. Now, PGT-M is done in 2 ways. There is a direct approach with Sanger sequencing. There is an indirect approach which is based on NGS. Now, though Sanger sequencing is a direct approach, it is economical, but it is highly error-prone. The risk of a misdiagnosis with the Sanger sequencing modality is anywhere between 2% to can go up to 10%, 12% in certain cases. Now, the NGS platform, however, is a linkage-based test, which means that it looks at the entire region which is carrying the mutation. So we are looking at multiple markers, not just one single point mutation. This significantly improves the accuracy of the test. And here, the linkage-based testing, which is the indirect testing, has 99% accuracy. Recently, Cooper Genomics from the US published their evaluation of around 28,000 cases of PGT-M that they did from the time they started offering the service. And their linkage-based testing said that the error rate was next to 0. They never had a misdiagnosis in any of the cases that were conceived with PGT-M. So that is the power of linkage-based testing. This is slightly expensive, but it is a more accurate version of the test. So this is how linkage works. We have the mother sample and the father sample. And here you have R, that is the affected child sample. So we have the complete signature of that particular region. And based on these three signatures, the embryos are designated as affected or not. So here we can see three of these embryos are identical to the R case. The yellow and gray signatures are present, so we know it is affected. So coming to the last part of my talk, I know I've taken a lot of time and it's exhausted. So coming to genetic causes of IVF failure. I frequently get questions on this particular segment. Why is my IVF failed? So it is important for us to assess at what stage of IVF has a cycle failed. Was it a stimulation-related failure? Was it sperm quality? Was it oocyte quality? Was it fertilization failure? Was it embryonic development arrest? There could be multiple or implantation failure. These are the multiple stages of IVF failure. So we need to troubleshoot them in a stepwise manner. So the standard protocol is first rule out non-genetic factors. So look at the laboratory, see if the culture medium was the right batch, see if other cases that are ongoing are working fine, was there any toxicity in the incubator, evaluate the consumables used, and then if all these factors remain stable and are not affected, then we look at genetics. Now, we already know the impact of chromosomal causes. Now, when it comes to genetic causes for embryonic failure, primarily it's the oocyte quality. Now, there are several genes involved in oocyte maturation, folliculogenesis, and formation of correct mature embryo oocytes. These genetic mutations basically hamper the formation of oocytes. So it can start right from differential response to your stimulation, but it can also include empty follicle syndrome, genuine empty follicle syndrome, which is also caused by autosomal dominant mutations. You can also have genes associated with fertilization failure, zygotic arrest, as well as early embryonic developmental arrest. So, well, I frequently, I'm now getting questions about TUB8. A lot of clinicians are asking me about TUBB8, because this is a gene which is involved in both maturation arrest of oocytes as well as embryonic developmental arrest. So what I'm trying to highlight here is you cannot look at a single gene alone when you're talking about embryonic arrest. Multiple genes are important for the maturation of multiple factors of the oocyte, and therefore you need to run parallel-based testing and not test only for one gene. When it comes to fertilization failure, it's very interesting because this was a very nice study. They evaluated both male and female factors affecting fertilization failure. So now, if you have a case of total fertilization failure and it's recurrent, then you need to evaluate both the male partner and the female partner. These are blood tests, basically. They're not happening on the sperm and the oocyte. These are genetic mutations which are sperm-related, like PLCG1, DNAH 17. You can see that these variants mostly are fixed by ICSI. They are not very conducive to IVF. This is conventional IVF failure. And even with ICSI, if there is a failure and the mutation, the cause is from the male factor, artificial oocyte activation with calcium ionophores is going to help us achieve fertilization and embryonic development. But if you are looking at oocyte-related mutations, example WE2, TUBB8, NLRP5, TLE6, here you can see that even though a very few percentage of the oocytes can be fertilized with ICSI, artificial oocyte activation is not going to help in such cases. This means that you will perform multiple ERT cycles with ICSI, with artificial oocyte activation, and still fail. And if your patient is not ready to move on to a oocyte donor program, you definitely need to do the test to understand if the problem is with the male partner or the female partner. This was a case of hydatiform mole, actually. This patient had 3 consecutive pregnancies with the hydatiform molar pregnancy. When we took a clinical history, her aunt also had a molar pregnancy. And she was a non-consanguineous couple, endogamous, and primary infertility case. They had also done one IVF cycle resulting in poor oocyte quality, and another cycle which had a couple of oocytes fertilized but arrested by day 3 because of the quality, and they were highly degenerated. When we did the testing for this patient, we actually found a mutation on a gene called NLRP7. The female partner was homozygous, that means she was affected with NLRP7 mutation. So NLRP7 basically affects maturation of oocytes and embryonic development, and she was not able to conceive with cell cycles. So we had to go in for a donor cycle for her. She conceived with the donor cycle. That was not a challenge. There is another category of genes called OZEMA. Now, OZEMA genes are involved in oocyte zygote embryonic maturation arrest, and these are the few genes listed. And there are multiple studies which we have seen for BGG4, for TAB8, for ZP1, ZP3, which results in embryonic arrest usually. This was a case for a patient who failed multiple cycles of IUI, had 2 cycles of ART, and all the time we have very few mature oocytes available, only 1 or 2. In 1 cycle, we managed to get 1 embryo, which was then transferred without testing. It was an unembryonic pregnancy. When we tested her, we found that she had a homozygous mutation on TAB8, which is an established, the way it has been shown earlier that when it is normal, the embryos will grow healthily, but if it's abnormal, they tend to arrest. So the diagnosis of maturation failure is basically if you have just only 2 mature oocytes out of maybe 6 or 8 oocytes with you. So there are technical challenges in genetic testing. It is not always going to be straightforward, but choosing the right panel matters. And because of the complexity of genetic disorders, the referring clinician needs to be clear on what are the actual manifestations of the case. Based on those cases alone, geneticists can act, because generally ordering on whole exome sequencing panel is not recommended in cases of IVF failures. If you do not take the specific phenotypes, my team has several times missed so many infertility related genes because when whole exome sequencing tests were given to us, infertility and the cause of infertility was not clear. We just had an information that it was primary infertility. But when we actually told our analytical team that we have a case now of oocyte maturation defect, the mutation was picked up. So it is important that clinical details are given. Pre-test and post-test counseling also is very important to be provided by using genetic tests because they have their own risks and own limitations. And we are medical legally liable if we do not have a clear informed consent taken before these investigations. So a multidisciplinary approach is the most efficient way in reproductive genetics. You have to work with a good team of reproductive specialists, embryologists, geneticists, genetic counselors to get to our goal for healthy pregnancies. Thank you very much. We can take questions if there are any.
Yes, thank you so much, ma'am. It was a very elaborative and very informative session. And I'm sure everyone must have taken some important points to imply in their clinical practice. If there are any questions, we can take the questions. Ma'am, meanwhile, can I ask some questions? Ma'am, you said something about germline mosaicism. What is exactly germline mosaicism? No, ma'am, you're not audible. Ma'am, just a second. I will just give me 1 second. Okay. You can unmute yourself now.
Yeah. So there are certain genes basically which can be normal in the blood sample but present in the gametes, which means that generally when we look at inheritable disorders, it's a blood test. So blood test is an idea of our germline. Whatever mutations are there in my blood will be present in the germline. Okay, because in blood we are testing white blood cells which have our inherited DNA. Sometimes what happens is, despite the blood sample, that means my white blood cells having normal genetic composition, the cells in the ovary or the cells in the sperm can acquire certain mutations during development. In such cases, the mutations are present only in the reproductive organs, but not present in the circulating blood. We call it germline mosaicism.
Ma'am, do we have cases of germline mosaicism in
There are a
infertility?
few genes not associated with infertility, associated with genetic diseases.
Okay. Okay.
So
And one more question I wanted to ask. What is your no, what is your opinion regarding DNA storage in recurrent miscarriage or in patients ART conceptions with pregnancy loss?
okay, that is a segment that I did not cover in my talk, basically recurrent pregnancy loss, because it's a huge topic in itself. DNA storage is very simple and easy process. But what it's very economical also. Once the DNA is extracted, it can be stored in any of your genetics labs for maybe 2 years, 3 years, even more. The advantage of storing the DNA is that on the day of the procedure of maybe DNC, your patient is not in a mindset to accept expensive genetic investigation. They are not in a mindset to even listen. But if we lose that opportunity to take the DNA out of that sample, we will never know what has happened to that pregnancy. What happens is after 3 months, when they have recovered from all the trauma, they come back to us and then say, "Oh, I should have tested, but I was not in the mindset to understand it then." Right? So for those cases, what we do is you perform the DNA and you give us a sample. We do the DNA extraction and we also do maternal contamination check, because at that time itself we need to know if the DNA is of the fetus or there's a mixture. Once the MCC is done, the DNA will be stored in the genetics lab. It is now accessible for you at any point of time. You can ask for a testing after a month, 2 months, 3 months, 5 months. That's anytime is fine. Second, if you have an anomalous baby and we are running a test, we have the diagnosis of a genetic mutation. Tomorrow, when they go for an IVF cycle and they're planning PGTM, we need the reference sample of the affected fetus. At that time, that DNA is very much useful. Sometimes PGTM cases cannot be performed efficiently if we don't have that index case. Then we have to go trouble their parents. The parents, both the partners' parents' samples are required, which becomes a more challenging approach. But DNA storage is very efficient. Even for babies who are in the NICU, whom we suspect of metabolic distress, we always suggest to store the DNA. It hardly costs around 2,000 rupees. So it is something that we can offer to any and all patients. They can choose to use it later or not. Usually every company will give you a 2-year contract for that 2,000 rupees. Until 2 years, they will store it. And after 2 years, if you still want to extend it, you can write to the company saying we would like to extend the storage of this sample.
Dr. Fiona, this is regarding the samples from the parents and the grandparents. So
Yes.
I think I always have this question in my mind that you suppose we say that this is the mutation and this is the effect of. So we know that this mutation will cause this disease. Okay, fine. So when we say that we are checking for that is a different story when we have the baby. But if we don't have the baby and we know that father and mother have this mutation, so we already have that mutation and we can develop the probe. Why do we need the grandparents? Because that puts a lot of money and financial things, and then still sometimes they are living in another part of the country, they have to call and all those things are there. So why can't we just do it with the parent sample?
I will just take you through my presentation and will help to explain this.
Yeah, I saw that, but I understand. But okay,
Yeah.
fine. Explain again, please.
I'll just tell you, ma'am, just 1 second for PGT. Yeah. So this is what we are talking about. So when we design probes for PGTM, it is not the probe is not a single point. The probe is an extended piece of DNA. Okay, it's not a small piece, it's an extended piece. It is supposed to fit correctly at the mutation location. Now, with embryonic testing, for blood samples, it's not at all a problem. But with embryos, it's a DNA amplified product, right? It's not a direct DNA from the embryo alone. We get the DNA and we have amplified it. That means we have bits and pieces of DNA which are copied and sitting with me. So the attachment of these probes may not be efficient if we don't map the SNP markers. Can you see these numbers here on my screen? RS.
Yes, I can.
These are what we call SMP markers. Okay. Now, these markers are usually present in the same family. We inherit them from our parents. But we also have some level of recombination that happens when the zygote is being formed, right? Sometimes these marks are lost and new marks are acquired. This means that me and my sibling, having inherited the same DNA copies from both our parents, will still look different even though we are the same gender. It gives us our own unique identity. Small traits changed based on this. If we don't have these markers established across two generations, which gives us evidence that this is a conserved marker. In the parents also it's present, in the affected child also it's present. Now we can make an assumption that this is a stable marker. It will be present in the embryos as well. Only once I get that information, the PGTM becomes accurate. Without that information, you have almost up to 12% margin of error on PGTM for the probe binding itself.
Okay.
Because the probe may not bind efficiently across all the DNA copies that we have.
Okay. Still a little confusing, yeah, but okay, fine.
Yeah.
Yeah.
It's like a jigsaw puzzle.
Yes.
It's like a jigsaw puzzle. It has to map this way. So what happens is if it just maps in one particular place, the probe may not bind efficiently and it might detach. That time, when I sequence, that information is lost.
Okay.
And what we call it dropout. It's called allele dropout. That region of the DNA is not mapped in my NGS sequencing. It can lead to diagnosis of an affected case as a carrier case, or healthy, a carrier embryo can be designated a normal embryo. So I can have misdiagnosis on the PGTM.
Okay.
That's why ESHRE guidelines tells us to use minimum 2 informative SMP markers, which is manually done in direct testing. With NGS, you have multitude of markers. We have like 15, 20 markers or even more than that when we do this analysis. It adds accuracy to PGTM.
Okay.
That's why we need 2 generations.
Okay.
It's not just, if you have an affected child, it's enough because the affected child is the next generation.
Okay.
If the child is not there, we need next generation.
What about like uncle, aunt, if like, for example, sibling of father or sibling of mother, that will not help?
If it's an autosomal recessive disease and the mutation is still there, then sometimes we use, for dominant conditions, we use affected relative. But for recessive conditions, it's better to have the first degree relative only.
Okay. Thank you.
Because the more further away we go from the pedigree, the more complicated other factors come in, because that uncle and have another family, one part of the DNA is from another family. Then we need to confirm that the uncle aunt has the same mutation as the affected parents that we are looking at. So sometimes those complicated factors come in, which means that if you're using other associated family members, first we need to do the genetic test, same genetic test, to see do they have the mutation or not. Then we have to incorporate into the PGT workup. So it will add cost and it will add time. That is the challenge. But the good news is we have newer versions of PGTM coming up, which are designed to look at the embryo directly on new level of sequencers. Only thing is, it is too expensive to be used in clinical practice at the moment. So at the moment, it's very, very pricey. Like one sample is costing 75,000 to run for the new modality. It's called next generation sequencing, third generation sequencing. It's called TGS. Those panels are now in research modality. It will take about a few years for them to come into clinical practice. At least in 5 years' time, we are looking at a scenario where we no longer need index case for this test. But until then, we have to use this method.
Okay. And please put some light on that day also you talked about origin from father or mother, like paternal origin mutation or maternal origin mutation. Now we can do that as well.
Yes, we can do that. It is very informative. In fact, we had a case where all embryos were aneuploid, and we did not, we thought it's the female because she was at 36 years. But then turns out all the aneuploidies were paternal in origin. And he was he had radiation exposure, the male partner. And that's when we knew this is a paternal issue. Even if we go for donor egg program, we still had to do PGT for them. So it is an informative test. And most of the West and European countries have moved to the new version of PGT, which incorporates SNPs. It's safer also. You know for sure that the embryo is a biological product of the parent. So you have parental quality assurance incorporated inside. So you no longer have to worry the parent patients are going to come to us later because the embryologist has probably mixed up the sample or the andrologist has mixed up the sample. All these problems are getting resolved now. So it has better coverage and more security in PGT-A for PGT-A.
One last question. Are there any guidelines for donor screening?
Not strongly well-established guidelines, but you have the SHA and ASRM guidelines for donor carrier screening. It's mainly based on the American College of Medical Geneticists. They recommend that they have 4-tier testing. First tier is our most common diseases, which is thalassemia, SMA, and the cystic fibrosis in their population. For us, it is thalassemia and SMA mainly, and sickle cell, of course, that gets included. Second tier are the most 100 most common conditions. Third tier is about 420 conditions, and the fifth tier is extended carrier screening, which looks at larger panel. So the larger panel can be extended to any number of genes that we want. It depends on the patient preference. So we have to give a genetic counseling, offer the choice to the patient, because aisa na ho that we do a common gene, and unfortunately there's a rare genetic variant which we have missed. And the patient says, "You would have told us, I would have done it earlier." This is what patients will do at the end of the day, right? They will tell us that if you would have offered us all the options, we could have chosen more wisely. So when we offer carrier screening, you would talk to your genetic service provider, how many carrier screening panels you have, and what is the coverage. Don't ask the gene list, it's exorbitant, it's too long. We won't understand anything. The geneticist only will come to know the carrier frequency of these genes. So you can explain to your patient, this is a concise panel, most common genes. There is an extended panel, these many genes. Is a highest coverage possible panel for whole exome and a few diseases. But what we need to remember while offering carrier screening is it is designed only for recessive and X-linked mutations. You still have dominant diseases which the company might choose not to report. You also have other diseases which are not included, like Fragile X, Huntington's disease. Those are repeat expansion disorders. They are not included in a standard carrier screening test. So the tests what are not included should also be informed to the patient. For late onset disorders are not included in the reporting, actually. That's all.
Are there any more questions? I think. So, ma'am, on behalf of MP chapter IFS and AMPOGS, I thank you again for this wonderful session on genetics. And definitely, it has given some important points to imply in our clinical practice. I also thank all the participants and the technical team for this session. And I hope we have such more academic sessions in the future. Thank you all and have a good evening.